Hello and welcome to another episode of the TheSynapse e-learning series where we'll be speaking about assisted reproduction. With us today we have Mr. Max Dingli, resident specialist in obstetrics and gynecology and also a member of the ART team at Mater Dei Assisted Reproduction Technologies. Thank you, Mr. Dingli, for being with us here today.
Thank you for having me.
On to my first question, what are the main causes of infertility which you encounter in clinical practice?
So we usually subdivide the causes of infertility, and infertility can be either because of a problem with the male partner, or else it can be because of a problem with the female partner, or else it can be a problem from both sides, or in quite a few number of cases it's actually unexplainable. In males, so I'm not going to speak too much about males because I'm a gynecologist, but in males mainly the problem is with the production or the quality of sperm. So you can have problems like obstructive problems, you can have problems with the actual production of sperm, which can be due to problems in the testes or due to problems in the hypothalamic pituitary or gonadal axis. In females, the issues we deal with are either ovulatory problems, so you might have anovulation, no ovulation at all, and that is common in polycystic ovarian syndrome, which is something that is quite common, especially in Malta. Besides the fact that because of this problem, women sometimes don't ovulate, and that would mean that they obviously can't get pregnant. You might also get problems with irregular cycles, so you wouldn't be able to actually pinpoint when a woman is ovulating, and that would make it more difficult to have a successful conception. And these irregular cycles can be caused by problems like polycystic ovarian syndrome. You can have issues like hyperprolactinemia, hypothyroidism. So these are other causes of infertility from the female side. And then sometimes you can get total amenorrhea, which obviously, since that shows a cessation of the menstrual cycle, would show that that pregnancy is quite difficult to achieve, and that can be because of hypothalamic causes like anorexia nervosa, or extreme athletes who have very low body fat levels. It can be iatrogenic, secondary to chemo, radiotherapy, or sometimes secondary to surgery if a lady has had an oophorectomy, bilateral oophorectomy, she obviously cannot ovulate. And in a lot of cases it's just idiopathic. We don't know why these things happen. Besides these ovulatory issues, there may be structural problems, and you could get problems at most parts of the female genital tract. So you might have an issue with the cervix, that mucus production might not be sufficient, and so the sperm cannot get through. But that's not particularly common. More common are tubal factors. So if the tubes don't work, if they're blocked in any way, then obviously the egg and the sperm cannot meet, and conception can't happen. And the common reasons for having blocked tubes are either previous surgery. So for example, if you've had a complicated appendectomy, especially if you've had peritonitis. There's also pelvic inflammatory disease, which is quite troublesome because women don't always know that they've had or that they have pelvic inflammatory disease. And then endometriosis is also an issue with tubal patency. And then you can have issues with the uterus itself. So you could have polyps or fibroids or uterine septa, which might cause problems mainly with implantation. So pregnancy might implant, but then not get much further. There's also a situation called Asherman syndrome, where there are a lot of small adhesions inside the uterus itself, and this is usually caused following over vigorous curettage of the uterus. So if a woman has had many procedures on the uterus, that might cause that. And besides all these, there's also endometriosis. We've mentioned it as a tubal factor, but endometriosis in itself does have a deleterious effect on fertility, because it creates an inflammatory environment inside the pelvis, and that is toxic to eggs, it's toxic to sperm, and it's also toxic to embryos. So it puts a spanner in the works at every single step. And then there are other issues that are maybe not so we don't think of them so much, but sexual dysfunction is sometimes an issue if the male partner suffers from impotence or inability to ejaculate, sometimes secondary to medication or stress. That could be a problem. If the woman has severe vaginismus and is unable to have sex, or dyspareunia, which can be because of endometriosis also. And sometimes there are just logistical issues, like a couple living in two separate countries and not meeting up too much. So those are usually what we look at when we're speaking to a couple who are unable to get pregnant.
So keeping in mind these varied etiologies which you've mentioned, and also the fact that obviously infertility, it's a sensitive issue, it's a stressful issue for the couple, how do we go about investigating infertility?
So the aim of investigating an infertile couple is to not only treat it's not only to get them pregnant, it's to also keep them in good health. And to do that, we need to look at the couple's general health, and that often involves speaking to them about weight loss. Obesity is a major factor in infertility. It can cause problems both with the man and with the woman. It can cause problems in natural conception. It can cause things like IVF success rates to be much lower in obese women. So keeping a healthy weight is a very important thing, as is smoking cessation. Smoking has a deleterious effect on the on sperm motility. It also affects the cilia inside the fallopian tube, so it affects both sides of the equation. So when we're investigating a couple, we do some general health tests. So we would take routine blood tests to see that the woman and the man are healthy, like a complete blood count, a liver function test. We check their thyroids because in women specifically that can cause menstrual issues. We also check vitamin D levels, because vitamin D has been implicated in healthy gametogenesis, and a lot of the population are actually vitamin D deficient. Besides that, for the man, the most important test would probably be a semen analysis, where we take sperm from the semen from the man and check it for the count, check it for motility, and check for morphology to see that that's all right. As regards women, we would need a few hormonal tests. So on day 3 of her cycle, usually we take an FSH, LH, and estradiol, and that would give us an idea as to whether her hypothalamic pituitary gonadal axis is working properly. We'd also check her prolactin, because because a high prolactin can cause menstrual problems. We check her free testosterone, because raised androgens could be an indicator of polycystic ovarian syndrome. We might check a CA125, because that is raised in ladies with endometriosis. Well, it can be raised in ladies with endometriosis. And one of the more important tests is in a 28-day cycle. On day 21, we like to take a serum progesterone. And the reason for that is that around 7 days after ovulation, the progesterone levels should be high in the blood if the woman has ovulated. Now, this is not a fantastically accurate test, because what might happen is that that woman's cycle might be 30 days rather than 28 days this time round, and you'd only know that after taking the test, but it does give us an indication. And another test that's quite important, especially for the management of infertile ladies, is anti-Müllerian hormone levels, AMH. What this shows is it's a marker of the potential ovarian reserve of the woman. So as you know, a woman is born with a certain number of eggs, and those keep decreasing until she reaches the menopause. And AMH gives us an indication where in that path she is, although it's not a definite sort of pinpoint. It helps us to manage ladies. Besides blood tests, then we'd go for structural tests. So what we're mainly looking at is checking the tubes. So we'd want to there are 3 ways that this can be done. You can do a laparoscopy, and that is the gold standard, but it's also the most invasive one. We'd inject some dye into the uterus and see whether it flows out of the tubes. You can also do a hysteroscopy whilst you're doing the laparoscopy, which would look inside the uterus, see if there are any abnormalities. But as I've said, it's quite invasive. You can do a hysterosalpingogram, which is pretty much the same thing, but without doing laparoscopy. We'd inject dye into the uterus and take an X-ray and see whether the dye flows into the peritoneal cavity. And you can also perform hysterosalpingo contrast sonography, or HICOSI, where we instill some fluid into the uterus, usually agitated water, and by ultrasound see whether the fluid goes through the tubes. And this can also be augmented by doing a 3-dimensional ultrasound, where we can see the inside of the uterus and see if there are any abnormalities.
Earlier on, you've also mentioned in vitro fertilization, IVF, and I understand that obviously it's a treatment, it's quite a well-known treatment for infertility, but how do we treat infertility? Is it only IVF?
Definitely not. In fact, IVF is there for very specific reasons. So we would go for IVF if there is a tubal problem, so if there's no other way of the gametes meeting. If there's severe oligospermia, or in which case sort of the natural methods are just not enough to get the sperm to the egg. And if we've tried other things and they've failed. So even though IVF is possibly the most effective way of treating infertility, it's not a blanket therapy. We have other things that we would do usually before IVF, and like I said before, most important things are lifestyle changes like weight management, smoking cessation, any medical comorbidities such as thyroid problems need to be dealt with. Any ladies who are trying to get pregnant should be on folic acid, because that decreases the risk of neural tube defects if they do get pregnant. We might supplement with vitamin D, as mentioned before, because ladies tend to be deficient in that. And in ladies with polycystic ovarian syndrome, we also might try therapies like metformin and myoinositol, and these help to regulate the hormonal status. Now, in cases where the cause of infertility is anovulatory, or sometimes even if it's unexplained, we can go for ovarian stimulation. And this is done with usually one of 3 methods. We can either use clomiphene citrate, or we can use aromatase inhibitors, or we can use gonadotropins. And the first 2 methods basically, in a nutshell, decrease the body's internal levels of estrogen, and so cause the pituitary to produce more gonadotropins. Or else you can give gonadotropins themselves, FSH and LH, usually by injection, which would stimulate the ovaries to produce more eggs. It's important that as this is done, besides just giving the medication, we do need to follow these ladies up by ultrasound. And the reason for that is if a woman has no response, then you might want to think of another therapy. If a woman has an increased response, if a woman has, say, 10 follicles, you might want to ask her to make sure she doesn't have sex, because otherwise she might get 10 babies, which is not a good thing. And this is usually followed by an HCG trigger, which causes her to ovulate. And then we'd ask them to have sexual intercourse. Sometimes, especially in cases of low sperm count, we can augment this by performing intrauterine insemination. So we would take a washed sample of sperm and actually inject it into the uterus, which would increase the efficacy of the possibility of sperm meeting the egg itself.
Mr. Dingli, I trust that you want to explain further about IVF with regards to the steps involved and also the risks involved.
Okay, so the steps of IVF. In IVF, we need to take control of the woman's cycle. So we start off by doing downregulation. This can usually be done either by taking the oral contraceptive pill, which brings it down to a baseline, or else by using a GnRH agonist such as buserelin. This allows us to take control of the HPG axis. And once a lady is downregulated, we usually move on to superovulation. Superovulation is done by giving the lady gonadotrophins, so mainly FSH, but also some LH, usually towards the second part of the cycle. And giving the woman supraphysiological doses of these gonadotrophins will allow the ovaries to overcome the mechanism of choosing one egg. So we would get hopefully quite a few follicles being produced. Throughout this process, we also administer a GnRH agonist or antagonist, which will stop the lady from ovulating of her own accord. We'd follow the follicles up by ultrasound, and once they've reached the necessary size, we would give a trigger which would cause the woman to ovulate. And this trigger is either an HCG injection, which would mimic the LH surge that would happen naturally, or else we can give an agonist, a GnRH agonist trigger, in the case of women who have been on a GnRH antagonist cycle. Once we've given this trigger, we then go on to perform oocyte retrieval, and this is the operative part of the IVF. During the oocyte retrieval, what we do is the woman is usually put to sleep, put under anesthesia, although it can be done under sedation, and we retrieve the eggs vaginally under ultrasound guidance using a probe and a needle. The eggs are taken, and the ones that are chosen to be fertilized are fertilized either through conventional IVF, where the eggs and sperm are placed in a dish and allowed to fertilize, or through ICSI, intracytoplasmic sperm injection, where the sperm is actively injected into the egg. This will hopefully form healthy embryos, which we allow to progress for the next 3 to 5 days. Usually after 3 days, any embryos that are formed are placed back into the uterus, and this is done through a catheter through the cervix, and usually doesn't require any form of pain relief because it's a relatively comfortable procedure. Any eggs that are taken and not used for fertilization can be frozen, and then they can then be used for any subsequent cycles, which should be easier on the woman because it doesn't involve the gonadotropin stimulation. So there's less risk of problems, which is what I'd like to tell you about now.
Because problems are encountered as well, unfortunately.
Exactly. So there are quite a few risks and disadvantages of IVF, unfortunately, even though it is probably the best way of assisting infertile couples. There are a large proportion of cycles that don't actually work. So disappointment is one of the biggest risks. Medication is quite expensive. Psychologically, it has quite a toll on couples. They have to spend quite a lot of time at clinics and doing procedures, and that takes them away from their work also. So there is a significant investment, both of time and money. As with all assisted reproductive techniques, multiple gestation is an issue, and with that you have problems like prematurity, increased risk of preeclampsia, increased risk of most pregnancy complications. There are the risks of the actual retrieval, so there's a risk of bleeding, infection, thrombosis, risks of anesthesia, and one risk which is quite uncommon but can be quite serious is ovarian hyperstimulation syndrome, OHSS, where the ovaries actually secrete a lot of fluid, which can cause problems with the woman's circulatory system, kidneys, and so on, and might require the woman to be admitted to hospital. So IVF is not a risk-free situation.
Exactly. I understand in your service you also offer a specialized environment, a specialized clinic for such couples. In fact, the Art Clinic in Mater Dei Hospital, apart from obviously guiding patients through this process, also helps with infertility in general. What can you tell us about it?
Yes, so the Art Clinic is a true multidisciplinary team. It's run by gynecologists, nurses and midwives, urologists, we have geneticists and counselors. We take referrals from any doctor, so it can be GPs or gynecologists themselves, and it is the point of entry for IVF at Mater Dei. Mater Dei offers 3 cycles to infertile couples who have been together and attempting conception for at least 2 years, and the woman has to be over 25 and under 43. And obviously IVF has to be medically indicated. But the Art Clinic is not only an IVF clinic, it is a clinic where all infertile couples can be seen and managed, and hopefully in a holistic and multidisciplinary way.
Thank you, Mr. Dingli, for your time.
Thank you.
Trust that this interview has helped our audience further their knowledge on assisted reproduction, and I also invite you to participate and further your knowledge by subscribing to the TheSynapse Facebook page and to our YouTube channel. Thank you so much.